Hello, I'm going to be going over the unfolding case study of acute head injury. Our group was Mary Byler, Lauren Davis, and Shannon Swantek. The scenario that we started off with was JR is a 28-year-old male who was doing home repairs. He fell from the top of a 6-foot stepladder, striking his head on a large rock. He experienced a momentary loss of consciousness. By the time his neighbor got to him, he was conscious but bleeding profusely from a laceration over the right temporal area. The neighbor drove him to the emergency department of your hospital. As the nurse, you immediately apply a cervical collar, lay him on a stretcher, and take JR to a treatment room. Primary head injuries occur at the time of the injury. This is where if the physician is unable to help the patient at this time, the biggest thing that we as staff are just trying to prevent any further damage from what already occurred prior to the patient getting to us. If there is any damage that is irreversible at this time, it's usually because of the displacement of physical sutures of the brain and the shearing of the axons. Secondary head injuries occur after the initial brain injury has already happened. The four main causes of a secondary injury include ischemia, neuronal damage, the cerebral swelling, and inflammation. This can happen within the first few days after the initial injury, and this is where as nurses we want to help make sure that there is adequate oxygen getting to the brain, that we're watching to make sure that there is any increased intracranial pressure, and if there is, that we are following our protocols and making sure that we are doing everything for our patient to help decrease the chances of any secondary head injuries. Steps that need to be taken to assess JR. The primary assessments that we're going to provide in the emergency department are making sure, his airway, breathing, and circulation is good. The vital signs. We're going to be doing the neurological assessment. With that, we'll probably be doing the Gramlos scale at this time too. We want to make sure that we know the level of consciousness, if there's any muscle movements that aren't normal, the pupil size is reactive, or if there's any irregularities there, reflexes, muscle tones, making definitely sure that he is able to breathe and his breathing pattern is adequate. And then we're going to be assessing the entire head for any other injuries besides the laceration that we already knew on the front. There could be other things that we are missing because we're focused on just the one. Alright, the secondary assessments that we're going to be doing in the ED will be gathering a detailed history of how the injury occurred, any pre-hospitalization care, past medical history including medications, allergies, surgeries, comorbidities, and conditions that could impact his condition. Also, we're going to make sure that we're doing thorough neural assessments, and then just making sure that he's breathing okay and that he's getting enough oxygen and perfusion throughout. Some of this stuff might have to, the gathering the details, some of this could come from the neighbor, or depending on how JR is doing in his mental status. If he can provide this, that's great. If not, some of this might have to come from family members when they arrive. Now we're going to discuss the 5 components of a neurological examination. First and foremost, we're going to make sure we check that mental status, the state of consciousness, if he's aware and responsive, he knows what's going on around him, the appearance and general behavior, his mood, the content of thought, and then just, the intellectual resources, if he was able to provide us with, his health history, also, that he knows where he's at, who he is, and, roughly the time frame that things are going on, making sure that when he does talk to us that his speech and language is adequate at this time. Alright, secondly, we're going to do a cranial nerve check As we know, the cranial nerves are, responsible for, control, the sensory functions, vision, smell, movements, the tongue and vocal cords. So we would get a little bit more in depth to see if there is any decrease in the functioning of any of those nerves that would kind of point us in a better direction for if there is some defects going on. Also, we're going to test to make sure that he's able to open and close his eyes, any pupil differences, muscle changes, strength in the facial muscles, that the gag reflex is present, um, tongue and lip movement, that he is able to smell, taste, hear, um, just, the stuff that we had learned about in our assessment course about the cranial nerves and what we're looking for is what would we be doing at this time. Thirdly, we're going to be looking at the motor system. The motor system includes the brain and the spinal cord, monitors pathways, and also the nerves and the muscles throughout the body. So we would be looking for any abnormal atrophy, any twitching, any abnormal muscle movements. Tests can be done to evaluate the strength of all the muscle groups. Here's where we'd see that Babinski response, where you take and you stroke the bottom of their foot to make sure that their foot responds like it's supposed to. If it fans outward, and it would be an indication of a brain or spinal cord injury. So that's something that we'd be looking at here in the third component of the neurological assessment. The fourth part we'd be looking at is the sensory system. We're going to be checking to make sure that they are responding like they should to pain, temperature, pressure. Stuff that we want to look at is this is where you could, do a pinprick in certain parts of the body to see if they can feel the pain or not. Also using hot and cold objects to make sure that they can feel the sensation of temperature throughout the body. Responses may be affected by how alert your patient is, how well rested they are. So if you're doing this, like in JR's case, it would maybe be something we'd look at doing later on if he's had too much going on, because if he is tired, that could also affect his response to this part of the examination. So this one can be repeated later on to see if there's change in different times of the day. But usually when you do this, this is one of the ones you want to test earlier towards your examination, just because it is so affected by how the patient is doing with their energy levels. And lastly, we're going to do the deep tendon reflexes. Alterations in the reflexes often are the first sign of neurological dysfunction. So we want to make sure we are observing these. Also know that when you are doing this part of the examination, that testing does not depend on the patient's cooperation, attitude, or awareness. So they could be somewhat in a lower state of consciousness, and this part of the examination can still be performed. This is where, when a specific part of the area of the muscle tendon is tapped with a soft rubber hammer, the muscle fibers should contract. Any abnormal responses may indicate injury to the nervous system pathways that produce the deep tendon reflexes, and that's something that we want to be aware of and make sure that that information is pushed forward. Alright, the most sensitive indication of a neurological change is the patient's level of consciousness, and this is where that Gramlow scale comes into play, that we are doing our checks, that we are making sure that we are writing them down, we are comparing to the last check that was done, and then if there's any changes in the level of consciousness, that we are making sure that our providers are aware of this. The next actions that need to be taken, well, of course, we're still going to be determining the severity of the head injury by using the Gramlos coma scale. We're also going to be having JR on the vital monitors and making sure that we're getting adequate vital signs throughout. This is where we might be obtaining that order for a CT scan, also with the possibility of increased cranial pressure. We're going to make sure that that head of the bed is up at least 30 degrees and that his neck is maintained in a neutral position. So the case study has progressed, and we find that JR has become unresponsive to vermal stimuli, responds to painful stimuli by abnormally flexing his extremities or that disorientated movement. He has no verbal response. The right pupil is larger than the left and does not respond to light. JR's Gramlos coma scale score at this time would be a 5, and this indicates that he has had a severe head injury. It indicates that he is critically ill and may need to be on ventilation support. He also could be having increased cranial pressure, and we want to make sure that we're monitoring that and treating it if it starts going out of range. All right, after we notify the provider of the change in the Gramlos coma scale, we would be probably intubating the patient to ensure that he has an adequate airway for optimal ventilation and oxygenation. We would also initiate intracranial pressure monitoring. We would order that CT scan if it has not already been done, possibly looking at getting an MRI and then an EEG at this time. We're going to look at normal intracranial pressure, or the ICP, and why increased ICP is so clinically important. Normal intracranial pressure ranges from 1 to 15. If there is an intracranial pressure greater than 15 in an adult for longer than 10 minutes is considered abnormal. Monitoring the ICP is so clinically important because the swelling increases pressure inside the head, which could then lead to further injuries of the brain. If the intracranial pressure remains high, it can also prevent blood passage to the tissue, which results in further brain injury. And this is where us as staff would be monitoring to see if there's any changes in the cranial pressure and making sure that if it is out of range that we are letting the provider know. 5 signs and symptoms of increased intracranial pressure. Well, you're going to have another decrease in that Gramlos coma scale. There could be vomiting, headaches, but if he's already in loss of consciousness, you probably won't know about the headache part. Lethargia and restlessness, and then also, continued changes in the mental status. Right, the physician has ordered a 25% mannitol solution IV, and we're going to talk about what is mannitol and why is it being administered to JR. Mannitol is an osmotic diuretic and is being administered to JR to decrease intracranial pressure. How does mannitol do that? Well, mannitol draws fluid from the intercellular and interstitial spaces into the vascular compartments. This is reducing blood viscosity and results in an improved cerebral blood flow. Our case study has progressed again, and JR is being transported to the radiology for a CT, where he is found to have a large epidural hematoma on the right side with a hemispheric shift to the left. He will be taken straight to the operating room for evacuation of the hematoma, and then while en route from the CT scan to the OR, the physician instructs the respiratory therapist to initiate hyperventilation for the patient to blow off more CO2. While he is in surgery, JR's family arrives at the emergency department with their faith healer. They ask that their faith healer anoint JR and pray over him. What should the nurse say? Well, the nurse should just inform the family that JR is currently in surgery and that to minimize any complication, the OR is a restricted area. The nurse can show the family to the waiting area or find them another quiet room where they could sit and pray together over JR as a family then. And then lastly, just inform them that they will be notified when they can see him once he is out of surgery and is allowed to have visitors. Our case study progresses. After JR's surgery, he is admitted to the neurological intensive care unit. What assessment indicators will be closely monitored in JR? The level of consciousness, the blood pressure. We're also going to be watching the Graham-Lowes coma scale, his respiratory function and ventilation, and then his pain level and how he responds to pain. JR has a intracranial pressure monitoring in place with the intravascular catheter. Nursing interventions related to JR's care while the catheter is in place include, and we decided it would be to continue monitoring the ICP waveforms using a aseptic technique when setting up the device, leveling the transducers even with the foreman of Monroe, administering a prophylactic antibiotic therapy, and then notifying the physician if the intracranial pressure is greater than 30. List 4 medication classifications that the NICU nurse could use to decrease or control increased intracranial pressure and the rationale for each. The 4 drug classifications that could be used for patients like JR are osmotic diuretics, sedatives, paralytics, and then barbiturates. The diuretic will help to decrease the blood pressure to prevent cranial hypertension, but make sure that you monitor it so that the patient does not become dehydrated. The sedatives allows for better ventilation and relaxation to reduce pressure. Also, it helps to decrease agitation in the patient. Make sure that you only are giving the short acting so that patient is awake for the neuro assessments. The barbiturates induce a coma to help control the intracranial pressure, prevent seizure, also lowers the cerebral metabolic rate. And then lastly, the hypertonic saline helps to treat for hypervolemia in the presence of intracranial hypertension and helps to control intracranial pressure. We're going to explain at least 8 independent nursing interventions and the rationale for each that would be used to prevent increased intracranial pressure in the first 48 hours post-operative. First, we're going to keep that head of the bed at least 30 degrees to help increase oxygenation and decrease pressure. We'll do an assessment for loss of consciousness, restlessness, dizziness, lethargia, and the ability to follow commands, reflexes and strength. We are going to monitor temperature. Hyperthermia can increase the cerebral metabolic rate. We want to reduce environmental stimuli, keeping the lights dimmed, noises down and stuff like that. We are going to perform the Graham-Lowes coma scale and then, notify the physician if there's any changes that occur. Assess for changes in the pupillary size. Dilation can represent increased intracranial pressure. Do a monitoring of fluid intake. Also, we're going to monitor the O2 and the CO2 levels to make sure that hyperventilation isn't occurring, because that can also increase the risk for intracranial pressure. We are going to monitor vital signs along with just the oxygen and the CO2 levels. And then we're going to make sure that we are administering those medications as prescribed. That will keep the patient calm and reducing any intracranial pressure, and then also to make sure that blood pressure stays low. And then our references.